The following is a paid program. WOR's airing of this program constitutes neither an endorsement of the products offered or the ideas expressed.
Welcome, everybody. It's the Radio Surgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple board-certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving into special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WOR studios in the heart of New York City. And now, please welcome Dr. Lederman.
Hi, it's Gil Lederman. We're live at the WOR studio. I'm here with Dariush Nurbaha, who's co-pilot today. How are you, Dariush?
Hi, Dr. Lederman.
And we want to thank Reggie, who's taken your calls. This is a live program, so feel free to call in, 1-800-321-0710, 1-800-321-0710 if you have questions, comments, concerns. And Ed is running the technical aspects of the show, so that's why it's so fantastic. So for all you listeners, we appreciate your support and calls. We had lots of calls after the program last week, and you're welcome to call during the program or after the program if you have questions, concerns, or comments. There's new news, and actually good news in the world of oncology. About 10 years ago, women in America were advised that estrogens could be harmful. Many women take estrogens, especially after menopause, to try to alleviate menopausal symptoms.
It's also good for osteoporosis, isn't it?
Right. So many women took to heart the fact that the use of estrogens were dangerous and actually cut out the use of estrogens. So it did cause some discomfort because of the relief that it produced for menopause symptoms. But because of women's response to this notice, two aspects of healthcare have improved dramatically.
What's that?
One, well, it's interesting, and it didn't get much play in the media, but this is new news, that, number one, breast cancer is decreasing in America. And many people believe that breast cancer incidence is decreasing in America because of the use of less estrogen.
Oh, wow. So less estrogen equals less breast cancer.
Less hormonally induced cancers in women.
Huh.
And then the newest news is actually that there's a marked reduction in ovarian cancer. So ovarian cancer is one of the most difficult cancers because it's deep inside the body. It doesn't usually produce any early signs or symptoms. So women are often shocked to find that they have the cancer with no real early warning signs. So since 2002, when the Women's Health Initiative released a report suggesting that hormonal use was associated with increased risk for adverse effects, the decline in the use of hormones has resulted in a marked decline in ovarian cancer. And in fact, the reduction is 2.4% reduction per year, and you're now talking over 10 years. So you've had a huge reduction in ovarian cancer. The most significant reduction was in white women who were aged 50 to 69 years of age. And those were the same women who often took the highest amount of estrogens.
Well, that makes sense then, huh?
It does make sense.
Yeah.
It's one of the few things in medicine that seems to make sense. That there's almost a cause and result effect.
Yeah.
So for women, there should be some rejoicing and understanding that, yes, holding back on estrogens does pay dividends, double dividends and yearly dividends. One is reduction of breast cancer,
And ovarian.
and two is reduction in ovarian cancer.
Yeah.
So,
Well, what's the alternative for those menopausal effects then, if they're not taking estrogen?
well, there are some alternatives. None are probably as effective as estrogen, but on the other hand, probably none are as dangerous as estrogen.
That's
either.
a great point, yeah.
So it's a big plus for women, and every listener should take it to heart and tell their loved ones that if you're taking estrogens, please think about the complications and risks.
Yeah.
There's other news. There's political news. The Supreme Court has ruled that genes can't be patented. So the genes that are in your body can't be patented and used by companies. And many people believe that will allow screening of genetic conditions at a lower cost and allow patients to have better access to medical care at less money. So the Supreme Court ruled unanimously that genes and the information they encode are not eligible for patents. And one of the biggest issues was BRCA, BRCA1 and BRCA2, which are genes that are associated with higher risk of ovarian and breast cancer for women. So it's another issue that affects a huge amount of the population.
I'm sorry, but was someone trying to patent these genes?
Yeah, there's a company in Utah that was trying to patent and it went to the Supreme Court. The company's named Myriad Genetics for two genes, BRCA1 and BRCA2. And if you remember, Angelina Jolie had bilateral mastectomies because she carries that BRCA gene that her mother had. Her mother died of breast cancer in her 50s.
Yeah.
Angelina Jolie was 37 when she had the surgery, and we're going to talk about her case either today or in subsequent shows.
Okay.
So most doctors believe that that's a big plus for medicine and that patients will have more access to better care at less money.
Yeah.
Right now, 250,000 women a year get analysis for BRCA.
Oh wow!
Genes.
I thought that was an expensive kind of.
It is an expensive test, and it's actually about the same number of women that have breast cancer. There's about 250,000 women a year with breast cancer, so they're doing as many tests as the number of women with breast cancer in America.
Probably not the same people, huh?
Maybe. I don't know. We don't know that. We certainly don't know it. Maybe daughters of women who had breast cancer want to know if they carry the gene, so they may not have the cancer at all.
Right.
Or they may have the cancer and they want to know are they going to pass it on to their loved ones.
Yeah.
So it can go probably both ways and probably does go both ways.
Yeah.
The chance of a woman in America having ovarian cancer is about 1%. And if you have BRCA1 or BRCA2, it goes up to 15 to 40%.
Wow.
So it's a high rate.
Yeah, huge indicator.
And that company was the only provider of BRCA1 and BRCA2. So they had huge stakes about.
Yeah, kind of like a monopoly on that gene, huh? Yeah.
It's business in America.
Yeah, well, this is good news then, because now other companies are going to come in and be able to provide the same service.
Well, they can't infringe on work of the company, but you can't patent
the
normal
gene.
genes.
Right.
So
right.
Your genes are your genes. There's other news. We have news about the treatment of metastatic breast cancer, and often a lot of our patients wonder, should they go on routine therapy or radiosurgery, or should they go on a clinical protocol? And lots of people go on clinical protocols. Sometimes they don't really understand, it seems, what a clinical protocol is. So I just wanted to talk about one particular clinical protocol for the treatment of breast cancer that was conducted here in New York City by one of the major hospitals. And the researchers tried to add a biologic agent, cetuximide, to cisplatin to increase the response rate for patients who are having metastatic breast cancer.
Sort of like a catalyst to the chemotherapy?
That's right. You got it. To see if combination therapy would be better than cisplatin alone for women with metastatic triple-negative breast cancer. So they were at estrogen receptor negative, progesterone receptor negative, HER2 negative. So these are proteins on the surface of the cancer cell, and estrogen receptor and progesterone receptor, like we talked about a few minutes ago, they're hormonal manipulators, and then the HER is another protein on the cancer cell. And the study took 173 patients who had previously been treated for metastatic breast cancer, which means the cancer had traveled, and they'd had one prior chemotherapy.
Okay.
Okay, so they had seen some chemo, but not very much chemo.
Right.
And they had breast cancer. And they could switch over. I mean, if you had one arm and it didn't work, you could switch over to the other arm.
Okay.
And the response rate was 20% in the combination and 10% in the cisplatin only.
Huh.
But the survival, the overall survival, was about the same. It was 12 months versus 9 months.
So the combination was 3 months more?
Right, and they did statistical analysis which showed that it was no different.
Oh, wow.
So it was considered a negative study, and there were adverse effects. The combination adverse effects included a acne-like rash, lowering of the blood counts, and fatigue.
This is a recent study, right?
Yeah, this is a new study. This is new this week.
Oh,
So
wow.
it's something for patients to understand that the routine and the not routine were getting about the same, and there were more complications in the new arm of the study. So people need to understand that the clinical protocol isn't a promise you're going to get better results or worse results. It's just a study.
Yeah.
And sometimes the difference is only in weeks or a month or two. So it's of concern, let's say.
Yeah, that is concerning because, you think here you are trying to get the most cutting edge, kind of give you an advantage on your disease, and you find out there's no difference really.
But that's what research is about. So sometimes patients have to understand that the research is for society or for the medical community, and they themselves may not benefit from the treatment that they've been put on, or may
Right.
not benefit as much as they wish.
Huh.
So it's something to ask if you're going on a clinical protocol. What's the data? Is there any data? Why am I doing this protocol? Has it been studied before? Is there any data before? Is my benefit going to be weeks, months, years, nothing at all? Well, it's important for every person to know about that.
Yeah, absolutely. Speaking of asking, if anyone has any questions they want to ask, they can call 800-321-0710.
That's right, 1-800-321-0710. That's the WOR hotline. Also, if you just want to leave your name and address, we have a free booklet and a DVD to send to you if you wish about innovative cancer treatment. Well, there's a new study out that looked at breast cancer and who gets the best results, and actually what happens if you delay treatment.
It can't be good, right?
Well, sometimes you'd think it doesn't matter very much, but it's interesting that actually it does matter. And this particular study looked at young women with breast cancer who had delays in treatment time, and they actually had less good survival. So the study looked at women who delayed treatment, and they had a shorter survival. This association was strongest in black women, those who had no insurance or public insurance, and women with lower socioeconomic status.
Well, sure, those are the ones that are most likely to delay then, aren't they?
It seems that way, unfortunately.
Yeah.
But some of these people have insurance, so even public insurance is insurance. And as a doctor, I certainly push ahead to give everyone treatment. So it's worrisome. And sometimes maybe the patient is reluctant to have treatment. So it's part of an educational process. But the research was from California. They evaluated 8,800 women aged 15 to 39 with breast cancer. So there's some very young women. Just because someone's 15 doesn't mean they can't get breast cancer.
Wow.
And the 5-year survival. So what percent of women were alive 5 years later who had surgery more than 6 weeks after diagnosis was 80%.
Oh.
And if you had surgery less than 2 weeks after diagnosis, 90%.
Wow.
So it was 10 points higher just by getting your surgery done a month earlier.
Wow.
The groups that had higher rates of delay were black women, Hispanic women versus white women. In blacks and Hispanics, it was a 15% of the group having delay versus 8% in white women. And based on insurance type,